Thank you very much, Xinjian. I'm going to share my screen so that I can speak from some overheads. And I would just start by talking about the innovations in COVID testing and related needs. But first, just to bring everybody onto the same page, I'd like to talk a little bit about the current understanding of COVID-19 after 18 months. As you know, early on, there was a hope that this disease would cause herd immunity and the transmission would stop and that it would disappear. Herd immunity is very simple to understand, but it wasn't understood earlier by the modelers who predicted it. What you can see here is with a reproductive number of 4 at the top, with a person who is infected, 4 people can be infected. But at the bottom in blue, if 3 of those people are protected against infection, then there's a decrease in transmission, and that can eventually decrease to 0. Herd immunity, though, is very difficult to obtain. This shows you herd immunity for rubella and measles, 2 diseases that have vaccines which prevent against infection. And you can see that we're using those vaccines. Over 90% of children in this case must be vaccinated in order to stop transmission of rubella or measles. But as I said earlier, there have been many estimates by modelers about what herd immunity might be for SARS coronavirus 2. It could be 50% to 75% of the population. The assumptions made, however, were that natural infection provides lifelong protection against reinfection and that vaccines provide lasting protection against infection. The reality is, however, that this is not the case. Vaccines and natural infection prevent serious illness and death, but they do not prevent infection in all persons. So what's important is to not talk about herd immunity, but to talk about population immunity as we continue through this presentation. And population immunity protects against serious illness, but not against infection. Natural infections contribute to population immunity. Natural infection protects against serious illness of COVID-19 in a reinfection, but the duration of that protection is unknown. At the same time, strict non-pharmaceutical interventions such as lockdowns decrease the ability to create population immunity from natural infection. But having said that, that does save lives. Vaccination protects against serious illness in over 90% of those who are vaccinated, but the duration of this protection is unknown. And persons vaccinated may be infected after vaccination, but are protected against serious illness and death. So using current medicines, vaccines, and diagnostic tests, we must use them to prevent serious illness and death while population develops and COVID becomes endemic. So what does this mean for low-income countries? Well, the types of diagnostic tests are 2. There's a PCR, which is very highly sensitive and specific, but it has very high cost. And therefore, it's limited in availability in low-income countries. Rapid antigen detection tests they have a less high sensitivity and specificity. They're inexpensive for most countries, and they can procure them, and they're available in low and middle income countries. The use of COVID diagnostic tests in patient diagnosis and management are to confirm clinical diagnosis, enable patients to get the right treatment, and at the same time enable their isolation rapidly to prevent spread of infection to health workers, families, and other contacts. Innovation in Cameroon, where the PCR availability was limited, substituted rapid antigen tests for PCR, as you can see in the green square at the top in the green rectangle. So every patient that's suspected of having COVID infection or who's being screened has a rapid antigen test. If that's positive, then they're a confirmed COVID-19 case, as you can see in the lower left corner in red. However, if that rapid antigen test is negative and the person still has signs and symptoms, then they do a PCR, and if it's positive, they're a confirmed case. But if the person is asymptomatic it's not considered a case. A very good innovation in a country where there was inability to obtain the the PCR testing. And as you can see, of the 80,000 reported cases or infections from Cameroon, 16% were detected with rapid diagnostic tests, a very important innovation. Diagnostic tests are also used for disease prevention and control, as you know, and this shows you the use of diagnostic tests to prevent and control infection. A good diagnostic test will enable contact tracing to decrease the spread and find the source of infection, as has been done in many countries, including Taiwan and in South Korea and in other parts of Asia, Singapore. And screening also decreases the risk of transmission in schools, workplaces, and at mass gatherings. It decreases, but it doesn't stop the risk of transmission. So it's important if you're at a mass gathering and want to prevent a major outbreak, that it will not prevent all transmission at these areas. So there's been some creative studies going on in lower and middle income countries looking to compare the rapid diagnostic test and the PCR for international travel. And what's been shown is that if you do pre-boarding screening, either with an RDT, rapid diagnostic test, the cheaper one, or the PCR, and then do it successively for 5 days afterwards, you have decreased the risk of importation by 91 to 95%, as you can see on the right, and you've not used any quarantine. Studies are going on in many countries to compare these two to see if there is an alternative to the PCR, which would be important for low and middle income countries. Types of COVID therapeutics have also become very available. As we know, oxygen, dexamethasone, which are medium or medium to high availability in countries, monoclonal antibody preparations, which are limited by their cost and their production capacity. You know, a treatment in the United States right now costs $2,000 just to give a monoclonal antibody to one person infected. Remdesivir has a low to medium availability in countries. This has been shown to decrease the time to recovery, but not increase survival. And molnupiravir, the newly approved antiviral, does in fact, if used early, cure infection or stop severe illness and death. So we have a great range of these, but there's been limited innovation on therapeutic use in lower middle income countries. Moving on to the types of COVID vaccines, we've been very lucky in having so many vaccines, and there are 4 different types of vaccine, as you can see, and you can also see the availability in lower and middle income countries is varied. So what we have are mRNA vaccines, viral vector vaccines, inactivated vaccines, and whole virus vaccines. These vaccines have been shown to maintain their efficacy in preventing serious illness and death despite the arrival of variants. What you can see in the 2 left columns is vaccine efficacy in preventing disease with the original ancestral and alpha mutation, and next to it you can see the efficacy at preventing infection. You can see that they're very efficient, 92, 94, 85% in preventing serious illness and death, but they're not so effective in preventing infection, which is what we've understood from the start. If you look at the next 2 columns, the right 2 columns, you'll see that the effectiveness of preventing disease in face of beta, gamma, and delta strains is a little bit less, but still high in preventing severe illness and death. But you can see their efficacy at preventing infection, these vaccines, is decreasing. And so they do not protect as well against infection as do the other vaccines against the original strain. Now, there's been lots of talk about eradicating COVID-19, and there have been several articles that speak about this. Well, let's talk about this a little bit, because the only viral infection that's been eradicated from humans to date is smallpox. Smallpox has been eradicated because there's a vaccine that's heat stable, but it more importantly gives lifelong protection against infection. Clinical diagnosis was easy in smallpox. Every infection was clinically expressed, so you could find where the disease was occurring. Transmission mainly face-to-face. Immunity permanent with no carrier state after sickness or after vaccination, and there was no animal reservoir. Well, let's look and see how COVID-19 stacks up to these. First of all, there is no vaccine that prevents infection, and the effective vaccine on severe illness and diseases and death is not yet understood fully. So vaccines cannot be used to prevent or eradicate this infection. Clinical diagnosis is not easy in COVID-19. Many cases are asymptomatic or have mild infections. So again, this would not be the same as smallpox, could probably not be eradicated using these two criteria. Transmission, however, is face-to-face or both, and so that's similar in both, but immunity is not permanent, and there's no carrier state. There is a carrier state in persons who are immune to infection, even if they are, and they're immune to prevention. So there's no long-lasting immunity, and we don't know whether there's an animal reservoir. We know that minks have been infected. They were culled, but they were able to infect humans again. And we know that deer in North America appear to be infected with this virus. So there are many reasons that this disease could not be eradicated using current vaccines. But even so, there is innovation in COVID-19 vaccines. There are studies using fractional doses, that means very small doses of the vaccine intradermally, and this has been shown to be effective for yellow fever, for polio, for other viral infections, and may be a useful way of decreasing the cost and increasing the availability of vaccines. So in summary, we need to learn to live with COVID-19. Natural infection and vaccination will provide population immunity. Population immunity will decrease severe illness and death of infection, but we don't know for how long. Population immunity will permit continued circulation of SARS coronavirus 2, and continued circulation of SARS coronavirus 2 will make this an endemic infection moving forward. So current vaccines, medicines, and diagnostic tests are very important to be used to prevent serious illness and death while population immunity develops, and also to prevent major outbreaks. So what do we have for lower and middle income countries? We have the ACT Accelerator, which is a partnership, which is attempting to make vaccines, therapeutics, and diagnostic tests available in countries, attempting to mobilize the resources to do that and provide these into countries. But lower and middle income countries will make their own decisions about whether they want to use these tools. Some will compare COVID-19 to other causes of severe illness and mortality. I've already heard countries saying malaria is more important to us than COVID, and they may choose other disease priorities. Others may prioritize COVID, but be unable to fully deliver vaccines to adult populations in need. And both these instances, in both these types of countries, population will continue to develop from natural infection. The ACT Accelerator will continue to mobilize resources and support the three pillars of vaccines, therapeutic and diagnostic tests, and population immunity will continue to increase, but variants could potentially arise that slow the process. So I hope I've been able to give you an overview of what might be happening in the future. Thank you very much for having invited me.